So, my name is Tamar Austin, and I would like to humbly and respectfully acknowledge the land on which I and the Birthplace Lab currently reside is the unceded, stolen, traditional territory of the Coast Salish peoples, including the traditional territories of the Musqueam, Squamish, and Tsleil-Waututh nations. I'm especially grateful to be a guest on this land as someone whose family originally immigrated from the Caribbean, my ancestors having been displaced there after they were stolen from their own lands. As we gather here today, we honor and recognize the importance of sovereign birth and the traditional birthing practices of the peoples whose land we currently reside. We commit to make space for and support the holders of traditional birthing knowledge who have remained steadfast in their practice despite the best efforts of colonialism and white supremacy. It is our obligation to continue to be proponents of reproductive and birth justice, especially in the face of deeply entrenched inequities. So I'd like to get started today first by welcoming everyone to our latest seminar series and introducing our three amazing guest speakers. So first we have Allison Campbell, who is a registered midwife and associate professor of teaching in the midwifery department at UBC. She is currently completing her PhD studies at the Institute for Gender, Race, Sexuality, and Social Justice, also known as the Social Justice Institute. Combining her personal and political interests, Allison Campbell's focus is social justice in perinatal health care and incarceration practices in Canada, and is informed by many years of learning, practicing, and teaching midwifery. Her PhD work focuses on perinatal experiences and reproductive justice in prisons in BC, specifically with regards to parenting behind bars. Allison has received funding from SSHRC and the UBC Public Scholars Initiative for her research and is a 2023 to 2024 recipient of the Liauw Teaching Prize. Dr. Jessica Liauw is our second guest speaker, is a maternal fetal medicine clinician scientist at BC Women's Hospital and clinical assistant professor at the University of British Columbia. She's completed her residency in obstetrics and gynecology at McMaster University. She completed her maternal fetal medicine fellowship, Master of Health Sciences in Population and Public Health, and the Clinician Investigator Fellowship at UBC. Her research interests include fetal growth restriction, preterm birth, medical decision-making, and the reproductive health needs of marginalized populations. And our final speaker will be Mo Korchinski, who is the Executive Director of Unlocking the Gates Service Society, UTG. Mo has had a long history of substance abuse and incarceration. She has a Bachelor of Social Work from Nicola Valley Institute of Technology, and her life's work is now dedicated to helping others break the cycle of incarceration. She is an advocate of people involved in the criminal justice system and continues to push for change at a policy level and increase support for her community. Mo feels strongly about the need to address trauma and support healing for people who experience incarceration. So without further ado, I'll pass this on to Allison Campbell, our first guest speaker, who will be introducing the current state of affairs related to perinatal care and women's reproductive health as it relates to incarceration.
Thank you, Tamara. Good morning, everyone. Thanks so much for having me, and thank you for that very thorough and lovely introduction, Tamara. I'm joining from the shared ancestral and unceded territories of the Musqueam, Tsleil-Waututh, and Squamish communities. And I'd also like to acknowledge the territories where the prisons designated for women are in this province, namely the Katzie, Matsqui, and Sumas territories. Katzie being where the provincial prison is, where people are serving sentences of up to 2 years, and Matsqui and Sumas is where the federal prison designated for women is, and that is people serving 2 years or more. So the people we're talking about today are also with us in spirit, I guess, from those communities. Our conversation this morning, focusing on reproductive health in prisons, provides us an opportunity to reflect on the very real reproductive injustices that Indigenous people have endured as part of historical and ongoing colonization in this country. In addition to an acknowledgement of the land we're all meeting from, I'd like us to consider that part of decolonizing work involves recognizing, attending to, and eradicating anti-Indigenous racism in the healthcare system, and acknowledging and repairing reproductive harms to Indigenous individuals and communities that have been and continue to be committed within it. It's something that as healthcare providers, I think we need to constantly remind ourselves of. Meanwhile, no conversation about prisons is complete without recognizing that despite making up only about 4% of the general population in Canada, about 40% of individuals in prisons designated for women are Indigenous. Indigenous women and gender diverse people tend to directly encounter the criminal legal system from younger ages, serve longer sentences, and be given higher security classifications than non-Indigenous women and gender diverse people. These are factors which have compounding impacts on their reproductive lives, spending more of their reproductive lives behind bars, introducing more barriers to maintaining relationships with their children, and having longer-term effects on their general and reproductive health. This is just one example of the genocidal effects of the over-incarceration of Indigenous people in Canada. In this way, the criminal legal system in Canada must be seen as a modern-day colonial practice. And again, as people who are engaged with prison health research, this is again something that I think we need to always keep at the forefront of our minds. So just a note on language, I tend to use the term prisons designated for women, which is a bit of a mouthful, but I do that intentionally as a way to recognize that trans and gender diverse people also live in and are incarcerated in prisons designated for women. And they are also included in this discussion. So I'm happy to talk more about that in the Q&A at the end if you have questions about it. But that's why I use that mouthful of a phrase. Also, in prison research, it's important to use person-first language. So you'll hear me using phrases like people experiencing incarceration, and I expect that Mo and Jessica also will do the same. I do this to remind us that the fact of being incarcerated is an experience that a person may have, but it is by no means a fixed identity, and it's certainly not the sum of who they are. So I'm going to open the discussion today by briefly introducing the framework of reproductive justice, which many of you here will be familiar with, and talk broadly about what we know about perinatal experiences of people experiencing incarceration in Canada in relation to that framework. I don't have any slides prepared, so I hope you'll be okay with just listening and absorbing what I'm saying without having something to look at. First, I want to outline for you who the people are that we're talking about. Women and gender diverse people form the fastest growing portion of the prison population in Canada, making up about 10% of the country's total prison population. And this number is very quickly increasing. Individuals who are admitted to prisons designated for women are of childbearing age. Roughly 18 to 35 is the main portion of that 18 to 35 are childbearing years, is by far the majority of the people who are incarcerated in Canada fall within that age group. Significantly, the vast majority, and it's an estimation because corrections doesn't actually report this data, but we estimate up to about 80% of people in prisons designated for women are the primary caregiver for children when they were admitted to custody. So they are of childbearing years and they have children. So the issues of reproductive justice are really very, very relevant to this population. So people are being held in prisons designated for women have, where did I go? Yeah, disproportionately high rates of physical and sexual abuse history and related trauma, substance dependence, and histories of mental illness. And as I've mentioned, Indigenous and racialized women are vastly overrepresented. Black women, for example, are disproportionately incarcerated at a rate 3 times higher than their proportion of the general population. And as I mentioned, Indigenous people are incarcerated at a rate 10 times higher than their proportion of the population. So reproductive justice, as many of you are well familiar, is organized around 3 principles of basic reproductive rights: the right to not have children, the right to have children, and the right to parent in safe and supported communities. Developed by Black feminists working in the abortion rights movement in the US in the early 1990s, the reproductive justice framework shifted the reproductive rights conversation beyond an individual freedom to choose argument of whether or not to reproduce. It recognizes that the binary and simplistic argument of pro-choice versus pro-life is inadequate to describe the complex social and economic realities within which people make reproductive decisions. And importantly, it locates the reproductive rights conversation within social contexts, including a critical recognition of systemic inequalities, resulting in variously applied privileges and oppressions. Before I go on, I'll ask you to consider for a moment the question, is reproductive justice possible in a prison context? So you can hold on to your answers and just think about it while I talk, but it would be worth considering while I go ahead and tell you about all the ways that we do not currently have reproductive justice in prisons in Canada. I wonder if you think that it's even possible to achieve. And if not, what should we do next? So I'm going to go through one principle at a time and talk just really generally about that theme. So the right not to have children. The right to not have children refers to an individual's right to make supported, informed decisions about their fertility, including access to contraception and the ability to terminate a pregnancy safely if desired. Surprisingly little data is available with regards to the experiences of reproductive decision-making for people in Canadian jails and prisons. For example, there's only one study directly on the availability of contraception in prisons. It's by our colleague here, Dr. Liauw, and her colleagues from 2016. This study, which surveyed women in an Ontario provincial jail, showed that women experiencing incarceration have higher unmet contraceptive needs and rates of abortion than the general public. I'll just tell you briefly about it. Of 85 respondents, 77% of them reported having had an unintended pregnancy. So that's 3/4. And only 28% reported that their most recent pregnancy was planned. This is compared to 73% of planned pregnancies in the general Canadian population. Meanwhile, 57% had undergone an elective abortion, compared to 37% in the general population. Of the individuals who were fertile at the time, but not actively trying to conceive, only 10% were using a reliable method of contraception at the time that they were admitted to custody. A 2023 scoping review on access to abortion and contraception in prisons revealed several ways women's access to contraception or abortion was compromised by a period of incarceration. In addition to lack of on-site access to contraceptive and post-pregnancy options, barriers included contraceptive coercion by care providers, financial costs, and disruptions to medical coverage and insurance status. The authors also discuss related barriers of prison policies, lack of information, fear of stigma, distance from surgical abortion provision, and trust in healthcare providers, in addition to jurisdictional regulations regarding abortion. So this was a scoping review which included articles written from 6 different countries. So not all of that applies directly to Canada, but the themes are there. Not to mention timing of care and the accuracy and completeness of information available to them. So the right to have children is the second sort of tenet of reproductive justice. And in this field, the right to have children refers to perinatal experiences, ranging from the beginning of pregnancy all the way up to the postpartum period. It encompasses a wide range of things, including the ability to choose to become and remain pregnant, have a safe and supported pregnancy, birth where and how one wishes, with a trusted care provider and other support people of one's choosing, and experiencing a postpartum period which provides options for infant feeding, which includes supported breast or chest feeding if desired. I should mention here that there are international standards set by the WHO, which establish that the same standard of healthcare should be available in prisons as in the community. Despite this, and setting aside for the moment that the standard of care in the community may itself not provide equitable access to this right, there are many examples of substandard perinatal care being the norm in prisons. Indeed, the prison itself creates many barriers to care. Research regarding the maternal and newborn health outcomes of prison-exposed pregnancies shows that people who are pregnant while incarcerated have increased risk factors for adverse pregnancy outcomes, are less likely to receive adequate prenatal care, and are more likely to experience negative birth outcomes, specifically preterm birth and low birth weight infants. I mean, that's just touching the surface. Some research in this area, mainly from the 1990s, has speculated on the relatively positive health effects of incarceration for women facing economic and social barriers to healthcare. But it's important to note that that is relatively positive impact of prisons compared to, not compared to the general population, but compared to other people who are experiencing social barriers to healthcare who are not incarcerated, but who are in the community. And that's an example, not of a success of prisons, but of a failure of a social safety net. So in other words, people are, for many people, going to jail provides access to stable housing, food security, and to healthcare, all of which may lead to improved health outcomes for this population. But it's only because they can't access those things in the community that can be considered to be an improvement. A researcher, an obstetrician who works in prisons in California named Carolyn Sufrin, Sufrin, writes about this in her 2018 book called Jail Care, and it's a really, really excellent read if you're interested in this area. The little research available on perinatal experiences of people during a period of incarceration in both US and Canada consistently shows that prisons do not adapt incarceration procedures for individuals who are pregnant, birthing, or postpartum. As a result, pregnant individuals in prisons are often deprived of adequate or desired food, exercise, over-the-counter medications, or simple accommodations to manage the discomforts of pregnancy. The ability to access appropriate, sufficient, and chosen healthcare services, such as seeing a midwife of one's choosing, for example, is severely compromised in prison settings, as is the ability to make informed and supported decisions about one's care. Individuals report extreme stress being pregnant in a prison setting, trying to plan for what's going to happen to their baby, never mind just trying to manage their own bodily autonomy, and just managing symptoms of pregnancy, often being worried about their own and their baby's physical safety. The result is that prison surveillance requirements contribute to birth experiences which are characterized as distressing, degrading, and disenfranchising, lacking in privacy or emotional support, and rife with dehumanization and stigma. Moreover, restraints, handcuffs, and shackles continue to be used when attending prenatal appointments and during labor, and in some cases during labor, despite clear international human rights directives to the contrary, and despite significant maternal and fetal risks. While there is very little data regarding individuals' experiences of birthing while incarcerated in Canada, the main themes in the literature reflect inadequate, delayed, and denial of medical attention, lack of supports, and egregious minimization of health-related concerns. Perhaps the most consistent and devastating outcome reported by people who experience pregnancy and birth in prisons is traumatic separation from their newborns after birth. Individuals are typically transferred back to prison, most often without their newborns, within hours or days of giving birth. Studies report unanimous trauma and shock at the time of delivery and immense feelings of emptiness and incompleteness once their baby's taken away. Not surprisingly, this tends to worsen in the postpartum period, increasing feelings of guilt, depression, anxiety, dissociation, increased incidences of self-harm and suicide attempts, and increased drug use prior to or upon release. And again, a lack of emotional support is widely reported. And postpartum health care, including support with suppressing milk production when you don't have your baby with you, is minimal at best. Remember, too, that health services are not available 24 hours a day in prisons, not in prisons designated for women. So nurses may be available during daytime hours, and there may be a physician who comes to the prison once a week or so, and who may be available on call. But even then, access to those health services relies on the willingness of guards to provide that access for people. So again, I'm really giving you the high level. I'm just skimming the surface of how deeply these kinds of pieces just really impact the experiences that people have. Finally, the right to parent children in safe and supported communities is the third tenet of reproductive justice, and it is by far the most complex, far-reaching, and systems change-oriented aspect of the framework. Parenting behind bars is one of the most prevalent themes in the research regarding the health needs of incarcerated women. So relationships with children and family is named as it's the most often cited health-related issue pertaining to women in prison. Remember that I mentioned that up to 80% of women in prisons have children. So it's a big issue, and that's no surprise. They care about their relationships with their kids. Studies on maternal-child connection and separation in prison settings reveal that keeping birthing parents and infants together supports positive physical and psychosocial outcomes, including breastfeeding and bonding, child development, and reduction of trauma for both parties. Studies further confirm that familial attachments are critical factors in mediating criminal behavior. So when people can stay connected with their families, they're less likely to reoffend when they go back into the community. Showing that, yeah, that's what I said. So women report going to great lengths to try to maintain connection with their children, despite many barriers and constraints of prisons. Mo is going to talk more about this and talk more about the mother-child programs that exist, at least on paper, in Canada. So I'll leave that part to you, Mo, to pick up. So stay tuned. There's a lot more to be said about this piece. And fine. Do you need me to wrap up?
Oh, no.
Okay. I'm almost there. And finally, I just want to make a note about, so there's those 3 principles of reproductive justice, but I just wanted to say that they all rely on the principle of bodily autonomy. So that people need the right to have bodily autonomy in order to have all of these things happen. And really, ultimately, bodily autonomy encompasses many things. It includes sexual freedom. It includes the right and ability to participate in sex work, for example, in a safe and supported manner, freedom of gender expression, and it also refers to personal physical safety, access to safe and appropriate healthcare, and freedom of movement. And above all, bodily autonomy can only truly exist within safe and supported communities where decisions are informed and made without personal, political, or economic coercion, without threat of violence, and with social supports. So prisons, by definition, design, and operation deny people the right to bodily autonomy. Routine prison practices such as cell and strip searches act as state-inflicted sexual violence and form an integral part of the structural violence of the criminal legal system. So when we think about reproductive justice in our communities, we need to remember to work towards reproductive justice in all of our communities, and that means we need to include prisons designated for women in this conversation. When I look at the issue of reproductive justice in prisons, it's clear to me that reproductive justice and prisons are incompatible with each other. The right to not have a child, the right to have a child, the right to parent that child in a safe and supported community, none of that can happen within a prison context. It might be interesting to know, and this is the last thing that I'll say, that prison-based healthcare in Canada falls under the jurisdiction of correctional services itself, for the most part. So healthcare within prisons is organized by correctional authorities. And the health professionals who work there are the staff of the correctional authority. So you can imagine how easy it becomes for prison policies, perspectives, and imperatives to cloud and override the health needs and provision of good healthcare for the people living inside those jails. BC is the only province where this isn't the case. Prison-based healthcare is organized by the Correctional Health Services here, a body which falls under the jurisdiction of the Provincial Health Services Authority. This separation only occurred in 2017. It provides some hope, I suppose, about organizing prison-based healthcare in a way that might approximate the healthcare in the community, but it remains to be seen how effectively those two systems can separate from each other. So for those of us working to establish justice and equity in perinatal services, the reproductive justice framework is a useful one to come back to. Justice and equity in perinatal services are a necessary part of a reproductive justice politics. But reproductive justice encourages us to remember that seeking justice and equity in perinatal services must extend to all members of our communities. This includes those who are kept out of sight behind bars for a time, It requires a radical rethinking of how we approach health, healing, justice, and equity across the many layers of our society. So I think my job was to identify the problem of perinatal care and incarceration. I think I've probably talked over my time, so I'm going to leave it there, and I'm going to pass it over. Am I passing it to Jessica or to Mo?
Well, first of all, thank you, Allison. I just want to state to everyone that we're going to have a question period at the end. So if you have any questions for Allison, please hold them until then. And we will be passing it on to Dr. Jessica Liauw, who will be sharing a call to action to bridge research and policy and introducing a new hub aimed at addressing these issues in a way that involves communities. Are you able to share your screen? Okay, perfect.
Give me 1 second. I'm just sharing it right now. Sorry about that. Okay. I think you should be able to see the slides there. Is that fine?
Yeah, that looks good.
Okay, great. So thank you everybody for joining, and thank you for the introductions, and Allison for a really comprehensive and thought-provoking introduction to the topic. I'm going to talk a little bit more about some sort of new collaborations and initiatives that we've started to put together across the country, and I'm very thankful that Martha's on the call here, as she's like a primary actor in this initiative as well. So really happy to see you there, Martha, also, and also for Mo being here as well, as she's also been like a very prominent part of the partnerships that underlie a lot of this work. So really glad to be here with everyone. So I'd like to introduce this new hub called Impact. So this is essentially a group of people that we're bringing together that's funded by the CIHR, Canadian Institutes of Health Research, through this National Women's Health Research Initiative, Pan-Canadian Women's Health Coalition, where we propose to essentially try to improve pregnancy and reproductive health of people experiencing incarceration through partnered knowledge mobilization. And so the reason that this, like the underlying concept that initiated this, is essentially that we know from current as well as emerging evidence that people experiencing incarceration face health disparities. That was very well outlined by Allison earlier. And the evidence that's emerging in health research is really helpful to show the magnitude, the characteristics, and the extent of these disparities, which is grossly underreported in comparison to other health outcomes, and so is really necessary. But really the next step after describing the problem is that we need to move beyond that and towards, trying to figure out how to actually eliminate these disparities or how to close these gaps. So description is sort of the first step and probably an integral step throughout this process, this transformation process, hopefully. But the next question in health research is often, okay, what are the interventions that we need? And so people with lived experiences and the organizations who advocate with people with lived experiences really have the best knowledge, or the most expert knowledge, about what problems are the most important, and have valuable insights into the programs and policies that can probably make a difference. However, funders or policymakers might actually require quantification of program and policy effects to support broader mobilizations of these programs and policies. And often, people with lived experience in the advocacy organizations on the ground may not have access to the resources needed to kind of do these wider program evaluations in order to get the broader support. So it's sort of like a vicious cycle. On the other hand, academic researchers do often have the methodological expertise to quantify the effects of programs and policies. And in fact, this is essentially their job, is to look at, how do we quantify rigorously the impacts of interventions across many health fields. But the purpose of this hub is to really bring those two perspectives together. So bring those two types of expertise together in order to basically catalyze a partnership that will be able to create the evidence that we need to push policy changes forward in a broader way. And so this hub is sort of like just starting up, but includes people from across the country and organizations from across the country. Some of them listed here. So you can see, including BC, Alberta, Ontario, Newfoundland, New Brunswick, and Nova Scotia. And really, our vision is to eliminate reproductive health disparities faced by individuals experiencing incarceration in Canada, and working towards this goal by prioritizing and mobilizing evidence on scalable policies and programs shown to improve reproductive health and health services. And so how will we actually do this? Well, this is sort of a 4-year plan. So the first step is to critically appraise or identify the research that is out there currently. And we'll be doing this by doing a critical appraisal through a systematic review of existing policies and programs focused on improving reproductive health of people experiencing incarceration, and then creating a best practices guide on appraising evidence for conducting quantitative analyses in this field to sort of generate further resources for further rigorous research as well. The next step will be to set priorities by convening a meeting with multiple groups, people with experiences and advocacy organizations, policymakers, researchers, and to bring those, all these different perspectives together to decide, what are actually the most important problems and questions and interventions that have been identified in the research or need to be identified in the research, and to create a call to action to fill the prioritized service knowledge gaps. And then finally, to create policies, and this will be done in collaboration with various professional organizations such as the Society for Obstetricians and Gynecologists of Canada and the College of Family Physicians of Canada, in addition to advocacy organizations such as Elizabeth Fry societies, and then to disseminate those policies, so really to bring those policies into action by creating other tools such as checklists that are more accessible to healthcare providers, for example, and also promoting sort of the next generation of health researchers and advocates in this field. And so one of our, just to kind of zone in on what we're immediately doing right now, which is the critical appraisal step, is really expanding on prior work that has been done by members of our hub, which I'll highlight here. The study was done or led by Fiona Kumjian, who is another one of our partners. And it was a systematic review of randomized control trials of interventions to improve the health of persons experiencing incarceration. And so 95 studies were identified. So this search was done in 2014. So definitely, a good time for it to be updated as well. But identified 95 studies, and a very small proportion of those involved women or individuals described as women. And there was a specific lack of evidence regarding interventions addressing reproductive health care. And so we are conducting an updated systematic review for specifically focused on those described as females and are incarcerated or up to a year post-release, and looking for interventions such as programs or policies or various treatments to improve reproductive health, and looking at outcomes such as sexual health, sexually transmitted infections, contraception, pregnancy, perinatal and pregnancy health, and abortion. And so our goal is to really include experimental and quasi-experimental studies. So these are study designs which are more rigorous in a quantitative sense to assess the causal relationship between an exposure, such as a policy or program, and the outcome of interest. And so many of us are familiar with randomized control trials, which are widely considered the gold standard for understanding causal effects between an exposure and an outcome. But we also want to include quasi-experimental studies, which are essentially can be thought of as natural experiments. So different ways to look at questions without necessarily mounting, a large randomized control trial, which also has its limitations because RCTs are typically on a very focused, specific population group, which is not always possible in the setting that we're interested in. And so to really be more inclusive, to include these other study designs that are still rigorous, but maybe more feasible to answer the questions we're interested in. And so this is just one example of a quasi-experimental study that might be of interest. And I really appreciate Allison's introduction to this topic. And as I mentioned, Mo has been a partner in making this study possible, as well as others on the call. But essentially, this is a quasi-experimental study, which we're taking right now to look at an evaluation of the impact of transferring responsibility for prison healthcare to the Ministry of Health in British Columbia. So as mentioned by Allison, on October 1st, 2017, BC did a policy change to improve healthcare in provincial prisons by transferring responsibility for healthcare from the Ministry of Public Safety to the and Solicitor General to the Ministry of Health in British Columbia, otherwise known as PHSA or Provincial Health Services Authority. BC was the third Canadian province to make this change. So Nova Scotia, as Martha pointed out in the chat, has done this, as well as Alberta in 2010. However, that is a minority of the provinces, and really a minority of jurisdictions globally have done this. So as Allison alluded to, in the majority of places, it's sort of the Ministry of Corrections or the Correctional Services body that governs healthcare within prisons. And although the UN and other international organizations have said that, it's advisable policy not to have this be the case, or to have ministries of health or health authorities govern healthcare and not correctional authorities, there have been really no previous evaluations to actually quantify the impact of this policy change. So unsurprisingly, people are not that motivated, probably, and this is just me sort of speculating, but probably not that motivated to make, a big policy change like that, or to have to mount a full, a response within their healthcare system if they're not really being compelled to do so. And how do we compel people to do that? Well, probably lots of different reasons, and it's probably multifaceted, including many political considerations in different jurisdictions, but also the lack of strong evidence that this actually would make a difference, I think is something that in health research we can really contribute to. And so our goals in this study are to determine if the proportion of women who received standard cervical cancer screening or standard prenatal care actually increased after the transfer of responsibility for healthcare compared with pre-transfer among those who experienced imprisonment in BC. And so this evaluation will hopefully inform decision-making regarding healthcare governance in prisons in BC and other jurisdictions in Canada and internationally. So how will we actually do this? So what is the kind of quasi-experimental study here? So here you can see we're going to do an interrupted time series analysis where we are going to be looking at a pre-intervention period and then a post-intervention period. So essentially, before 2017, there would have been a rate in the outcomes, for example, like number of people getting routine screening for cervical cancer. And we would expect this underlying trend to sort of continue in a certain fashion. And then with this change in policy or the transfer of responsibility of healthcare, this may have changed. And so this is what we seek to understand, what this difference is between what was going on and what actually happened after 2017. And then using sort of different methodological considerations to understand what that counterfactual trend would have been, and also to look at a control such as Ontario, who did not make the policy change. So we've spent quite a number of years getting access to the data, again, with help from many parties on this call. And we're just about to start planning the analyses and sort of, working with the data now. So just to reiterate how this all fits in together to the Hub's activities: critically appraising the evidence. So what is the evidence that's out there, setting priorities, which evidence is important, and then creating the policy, as I mentioned, translating that evidence into policy, and then translating that policy into practice. And so just wanted to give a short intro, but thank you very much for your attention. And here's our contact. So please reach out if you have any comments or questions. I'll stop there.
Thank you, Dr. Liauw. So we're going to finish with Korchinski, who will recount the current issues related to mother-baby provincial programs and how it affects the mother-baby connection in BC and Canada.
Thank you. Thank you for having me, and welcome everybody. I may be speaking about my own personal experience. I was actually incarcerated when BC at Liauw Correctional Center had the mother-baby program in 2005 to 2008. During that time, we had 10 babies come back to the correctional center, and I got to watch firsthand how life-changing it was for the mothers and the babies. Not just for the moms, but for all the women. As Allison mentioned, most women that are incarcerated we have children or we have children or women who are going to be able to have children. And at first it was a slap in their face when the first baby came back for all the women in there who didn't have their children. For example, me, I had 3 children. I had no idea where my children were, lost contact with them when I was in my addiction. And, got me to start wondering, what my children were like, what they looked like, wanted me to start healing the brokenness of not having my children. Mother baby program was from 2005 to 2008. And like I said, 10 babies. At one time, we had 4 babies at the correctional center. And you ever walk in a room and somebody has a baby, the whole room atmosphere changes. This happened in a correctional center as well. Women were, really more aware of their behavior, more aware of not bringing drugs in, affecting this baby program. So sorry, I don't know why I'm so nervous. I haven't talked about this for a while. I've had the joy of watching these babies grow for the last 16 years since the program stopped. We have one that's graduating this year. The mothers are doing amazing. The outcome of the 10 babies, all the babies ended up staying with their moms after the program, after they left corrections, and not one ended up in foster care, right? Where else do you see a program that successful? When in 2008, we had 5, when the program shut, we had 5 women who actually took BC Corrections to court, to the Supreme Court, and they won in Supreme Court that it was the right of the baby to have the bonding, to be able to breastfeed. While we were going through the court, I'd get phone calls through my organization for women who were pregnant and terrified, crying, not knowing what's going to happen to their baby, what's going to happen to them. And the stress this has on a mother and a baby is not good, right? Even through the mother baby program, women were never told they were allowed to keep their baby until after they gave birth. So as they're waiting to find out if they're going to be able to be part of the mother baby program, of course, all the stress, and of course, we know that affects baby's weight, the stress on the mother. Yeah. Like I said, it also affects all the women, and I think, one thing what we didn't do a good enough job when we did this in Alloway Correctional Center was give support to other women, right? How do you help other women? When I tried to connect with my children when I was incarcerated, no one knew how to help me, right? So I think we could have done a better job and we would have healed more women. It holds women back because when you get into jail, you're off the dope and all those guilt and shame comes back in about, walking away from your children. Most people have no understanding how a mother could walk away from their children. That talks about how powerful addiction is, talks about how powerful the trauma we all have gone through. And then when you get off the dope, all the guilt and shame start coming in, and being able to support women through that, I think we would have seen more women reach out. I know a lot of us actually did reconnect with our children when we got released during that time because of the mother baby program. And now, it's sad that we're not, honoring women and mothers. I think where else is a safer place? I know there was a lot of controversy through the media and through people in the public saying babies shouldn't be in prison. But where else is a safer place? You're on camera 24 hours a day. You're getting support. Maple Ridge community. I happen to live in Maple Ridge, where Alloway Correctional Center is. We had so many community organizations come in and support the women and support the babies. Be able to teach them how to bond, how to be a mom, how to breastfeed, how to pump. Once that program stopped, and the women were going, giving birth, and sometimes 3 hours later, they were brought back to the prison without their baby. Like, how inhumane is that to do, especially in Canada? And then they were told they have to breastfeed and that the milk would go to the kids. And like, I think Allison or somebody said, we don't have 24-hour nursing there. So a lot of times they couldn't breastfeed, and, how uncomfortable that is for a mom not being able to do that. And then once they get released, I'm not sure realize how hard it is once a woman gets released to reconnect with their children when you have a past of crime, addiction, you know, and women try, I've supported so many women trying to reconnect with their children once they're released, you know, and they go through all the mother baby programs they're supposed to be doing, and they still can't get access to their children, and they just give up and they go back to their addiction. And, you know, nowadays we all know we're in a drug crisis, you know, it's life and death for a lot of these women. And, you know, we could give them some hope and dignity and being able to access their children and support them through this. And I think, you know, a lot of people say jail isn't the place, but where is? Like, we don't, you know, for me going to jail, I couldn't go out the back door. I had to face my demons. And what's a better place to do it with a bunch of peers? You know, jail becomes a community of your own and your own family. I know we have a couple of my friends on this call, you know, what I met when I was incarcerated. You know, 90% of the people I still associate with, I met when I was incarcerated. You know, we're the biggest support, and we feel safe with our peers. So that's just a little bit about it. I know after the court case where, you know, the women won and the babies won, we still have not had a mother baby unit opened. Is still on paper, you know, across Canada, and it's sad because I think we could make it a huge change and show how it's supposed to be done, because you know what, Alouette Correctional Center did it for 3 years. So that's all I have to say. Thanks.